Hello, this is Mrs. Mattingly again. This is another pre-lecture Collaborate for your acute neurology content. I know that the Collaborate for increased intracranial pressure was pretty long. I felt it too while I was recording it, so hopefully this one will be a little bit shorter. The first couple of slides are your outcomes and the cues, so I'm just going to click through those. Okay, here's the first slide. We're talking here about head injury, and a head injury can be any type of an injury or trauma to the scalp, the skull, or the brain. One of the most serious types of head injury that we encounter are traumatic brain injuries, and we call those TBIs. There's a lot of different causes, and I've listed those for you, or some of them, not all the causes, but some common ones on the slide for you. It's really difficult to really get a good assessment of how many head injuries there are, because a lot of times the person will actually just die on the site, or they'll have a head injury but they won't think it's very important, so they won't come to ER. And then sometimes we probably don't have the greatest accuracy in assessing the amount of head injuries that we see. But we do know that if a patient comes into the hospital and is hospitalized with a TBI, they have about a 20% chance of dying. We also know that we have at least 5.3 million Americans living with long-term consequences of TBI. So those are just some things to remember about TBI. Head injury in general gives us a high potential for poor outcomes. Deaths from head trauma occur primarily at 3 different points, and I've got those listed for you on the slide. The majority of deaths after a head injury occur immediately after the injury, either from the direct head trauma or from a massive hemorrhage and shock. Deaths occurring within a few hours of the trauma are caused by progressive worsening of the head injury or internal bleeding. And our ability to immediately recognize changes in the neurological status and then to get things rolling so we have rapid surgical intervention is absolutely critical to prevent deaths in this really narrow window. When we have deaths that occur 3 weeks or more after injury, that results from multi-system failure. And a lot of times, really staying on top of things and having really good focused nursing care in that interim time is really crucial to decreasing the mortality risk and optimizing patient outcomes. You can see here we're again talking about the Glasgow Coma Scale, and we do know that the Glasgow Coma Scale is a direct predictor of survival. So if they come in and they've got a Glasgow Coma Scale of less than 8, they've got about a 30 to 70% chance of surviving. If they come in with a Glasgow Coma Scale greater than 8, well, I'm missing the 8 there, but greater than 8, they've got a 90% chance of survival. Moving on to types of injuries. The first one we're going to talk about are scalp lacerations. We're not going to say much about them. They're easily recognized as an external type of head trauma because there's a lot of vessels in the scalp. We have a lot of bleeding. So our major complications are what would come with that, if you just kind of think it through, are blood loss and infection. That's all I'm going to say about that. I'm going to try to move to the next slide. Woo! Okay, the next one we're going to talk about is skull fractures, and I am going to talk a little bit more in depth about skull fractures. Skull fractures occur frequently with trauma. There's several different ways to describe them. We can talk about them being linear depressed, is one way we can talk about it, or we can talk about them being simple, commuted, or compound, or we can go from the approach of saying they're closed or open, okay? A linear fracture occurs when there's a break in the continuity of the bone without an alteration in relationship to the parts. And this is often associated with low velocity injuries. We have a depressed skull fracture when there's an inward indentation of the skull, and this usually comes with a blow of great force or a powerful blow. A comminuted fracture occurs when there's multiple linear fractures with fragmentation of the bone into a lot of pieces. And this is usually the result of a direct high momentum impact. An example of a compound fracture is when you've got a depressed skull fracture and a scalp laceration with communicating pathway into the intracranial cavity. This is associated with severe head injury. Fractures can be open or closed, depending on the presence of a scalp laceration or an extension of the fracture into the air sinuses or dura. The location of the fracture usually determines the clinical manifestations that we're going to see. Some major complications are intracranial infections and hematomas. We can also see meningeal as well as brain tissue damage. If we have a patient who has a basilar skull fracture, and I'll repeat this later, but if we think they have a basilar skull fracture, we know that they've got a basilar skull fracture, then if we're going to use a nasogastric or oral gastric tube, it should always be inserted under fluoroscopy. We're going to talk a little bit specifically about basilar skull fractures because this is a specialized type of linear fracture that occurs when the fracture involves the base of the skull. We've got some manifestations that generally will evolve over several hours. The symptoms are going to vary with the location and the severity of the fracture, and it may include cranial nerve deficits. One of the things, and there's a picture of it up here, that we can see is battle sign, and this is when we've got post-auricle ecchymosis. So if you look over there on B, that's going to show you otorrhea, but it's also going to show you post-oral ecchymosis down there in that kind of bruised area, okay? And then also if you look at C, this is another picture where you can see that post-auricle ecchymosis, so it's kind of like bruising almost over there behind the ear, okay? And then you can also have periorbital ecchymosis, which is the raccoon's eyes, which is shown over there in A, okay? This fracture is usually associated with a tear in the dura, and so therefore it's very common that we're going to have a leakage in cerebrospinal fluid. And you can see that where we've got that demonstrated in both A and B. And in A you see rhinorrhea, where you've got leakage through the nose, and you've got in B you've got otorrhea, where you've got leakage from the ear canal. If you've got rhinorrhea or otorrhea, then you generally know that that fracture has transversed the dura. You can also, rhinorrhea can also come across as postnasal sinus drainage. So it's important to really monitor rhinorrhea because it can be overlooked unless we're specifically thinking and looking for this finding. The risk of meningitis increases with a cerebral spinal fluid leak. And so if we've got any kind of a CSF leak, we should start antibiotics right away. And the reason we're starting those right away is we're trying to prevent the development of meningitis. There's a couple of different ways that we can test to determine whether or not fluid is leaking. From the nose or ear is CSF. The first method is we can use a dextro stick or test tape strip to determine if there's glucose. And CFS is going to give you a positive reading for glucose. We know that from way back in that first nervous system lecture. Another thing we want to be paying attention to is whether or not there's blood present in the fluid. And the reason we want to know that is that blood also contains glucose. So if there's blood present, you could have the fact that the blood is giving you the positive glucose as opposed to true glucose. I don't know if that makes a lot of sense or not, but at any rate, in this situation, you're looking for the halo or ring sign, and that is shown down there on D. And the way that you do that is you just allow that fluid to drip into like a white gauze, or you could use a paper towel, then you watch it. After a few minutes, the blood is going to come together in the middle, and then you're going to have a yellowish ring that goes around the blood if there's CFS present. You always want to note the color, appearance, and amount of the leaking fluid because both tests can actually still give you a false positive. So you want to stay on top of the details of the leaking fluid. Types of head injuries, I've listed them for you as diffuse, focal, and then minor, moderate, and severe. You can see minor, moderate, and severe is defined by the Glasgow Coma scale. Okay? A diffuse injury might include things like concussion or diffuse axonal damage. And this is going to be a damage to the brain that cannot be localized to one particular area. In a focal injury, that could be something like a contusion or a hematoma. And the key with this is that the damage can be localized to a specific area of the brain. And then I've got here your ratings by the Glasgow Coma Scale. A diffuse injury. We're going to talk about concussion. Concussion is just a sudden, temporary mechanical head injury. And what this does is it disrupts the neural activity and it causes a change in level of consciousness. And this is considered to be a minor diffuse head injury. The patient may or may not lose consciousness with this injury. What you're typically going to see is a brief disruption in level of consciousness. You might have some amnesia involving the event, and that's called retrograde amnesia. And you could see a headache. Usually, you're going to see these symptoms are going to last for a short duration. If the person has not lost consciousness or consciousness is less than 5 minutes, they're usually going to be discharged. They're going to go home with specific instructions, okay? Then we're going to move on to the next slide's going to actually talk about post-concussion syndrome. Post-concussion syndrome can develop with some individuals, and it's usually about 2 weeks to as much as 2 months after the injury. And then I've listed for you the symptoms that you most commonly see. What you start to see is this syndrome will impact the person's ability to perform their activities of daily living. Although we generally think that concussion is benign and usually it's just going to resolve itself, the symptoms can be the sign of something more serious or progressive, especially if that patient has had prior concussions or head injuries. It's always important to give really good information to that patient at discharge of what to watch for and how to accurately report symptoms or changes in the neurological status. Diffuse axonal injury is sometimes abbreviated as DAI, and I've got a pretty good definition for you down there, but it's a widespread, it occurs after it can be a mild, moderate, or severe TBI. The damage occurs primarily around the axons in the subcortical white matter of the cerebral hemispheres, basal ganglia, thalamus, and brainstem. We used to think there had to be an immediate tearing of the axon from the traumatic impact, but now we're thinking differently. We're thinking that the trauma actually is from the swelling and the disconnection of the axon, so it changes the function of the axon. You can see a lot of variations in the symptoms that you would see, but typically you are going to see decreased level of consciousness. You're going to see increased intracranial pressure. You could see either decorticate or decerebrate posturing, so you could see either or, and you're going to see some global cerebral edema. We do know that 90% of DIA patients result in staying in a persistent vegetative state, and if we want to, with a patient that comes in with DIA, we want to quickly triage them to ICU because they need to be monitored for increased ICP. They need to have immediate transfer to an environment that can have all of the monitoring aspects that we would have in an ICU. Focal injuries. Focal injury can be minor to severe, and it can it's localized to an area of injury. I've listed for you 4 different kinds, and then we're going to go through those kinds. First, we've got lacerations. This involves an actual tearing of the brain tissue, and it's often in association with depressed or open fractures, as well as penetrating injuries. Okay? The tissue damage is severe, and surgical repair of the laceration is impossible due to the nature of brain tissue. The medical management consists of antibiotics until meningitis is ruled out, and then we want to prevent secondary injury related to increased intracranial pressure. I'm sure you're getting tired of hearing about increased intracranial pressure by this point. If the bleeding is really deep into the brain tissue, we can have both focal and generalized symptoms. We can have hemorrhages, and the hemorrhages can be intracerebral, subarachnoid, or intraventricular. Most commonly, we're going to see intracerebral. The hemorrhage is going to manifest itself as a space-occupying lesion, and so you're going to see things like unconsciousness, hemiplegia on the contralateral side, and you would see a dilated pupil on the ipsilateral side. Remember, ipsilateral is same, okay? A subarachnoid hemorrhage and intraventricular hemorrhage can also occur. Then moving on to contusion, that's a bruising of the brain tissue. It's within a focal area. It's usually associated with a closed head injury. It can contain areas of hemorrhage, infarction, necrosis, edema. It often occurs at the injury site, at the fracture site. This is a picture showing you Coup-Contrecoup injury. And with a concussion, the phenomenon of Coup-Contrecoup is often noted and can range from being a minor situation to being very severe. The damage from a Coup-Contrecoup injury occurs when the brain moves inside the skull due to a high energy or high impact injury. You've got contusions and lacerations that occur both at the site of the direct impact on the brain, on the skull, which is the coup, and also at the secondary area of damage on the opposite side away from the injury, and that's called the contrecoup. This then results in multiple contused areas of the brain. Generally, the contrecoup injury tends to be more severe, and the overall patient prognosis depends on the amount of bleeding around the contusion site. Some more focal injuries of contusion. Contusions can continue to bleed and rebleed, and then they'll look almost like a blossom of flowers on subsequent CT scans. If you start to see that blossoming approach, that means that you've got a worsening of the neurological outcome. Our neurological assessment, we need to pay attention because we're looking possibly not only for generalized manifestations, but also for focal manifestations, depending on the size and the location of the contusion. It's very common to have seizures as a complication of a brain contusion, and usually that's within the first 7 days of injury. If the person is utilizing anticoagulants, that's of special concern, and a lot of elderly people are utilizing some type of anticoagulant therapy, and if that's the case, generally, if they fall and they have a contusion and they're already on an anticoagulant therapy, then the injury is going to be more severe. So basically, then you can translate that back out and say that anticoagulant use is associated with increased hemorrhage and a higher mortality rate. Hematomas. The picture here is a picture of a classic epidural hematoma, and typically what you're going to have is an initial period of unconsciousness followed by a period of brief lucidity, and then you're going to have a subsequent decline in level of consciousness. Other things you might see, I've got listed on the slide for you, is that headache, nausea, vomiting. You need a rapid surgical intervention in order to evacuate the hematoma and prevent cerebral herniation. So if we use surgery combined with medical management for increasing intracranial pressure, we can dramatically improve outcomes. But again, go back to those, that first part, that you're going to have that initial period of unconsciousness, then you're going to have a brief lucid period, and then follow that with a decrease in level of consciousness. And the bottom line is we need to get them to surgery and get that hematoma removed. Subdural hematomas. It results generally from an injury to the brain tissue and its blood vessels. The veins that drain from the surface of the brain into the sagittal sinus are the most common source of subdural hematomas. Because the subdural hematoma is usually venous in nature, generally that hematoma is going to be a little bit slower to develop. However, it is possible to have an arterial bleed, and in that case, then just forget what I said, because you're going to have a rapid increase in size, and it's going to develop quickly. You can consider that subdural hematomas may be acute, subacute, or chronic in nature. I'm going to talk about all three on the next slide. So if we're talking about acute subdural hematomas, they're going to manifest within 24 to 48 hours of the injury. Your symptoms are similar to those associated with brain tissue compression that you would see with increased intracranial pressure. You're going to see a decreased level of consciousness, you're going to see a headache, and it's the size of the hematoma that's going to have a direct impact on how that patient's going to clinically present, and you're also going to know that the size of that hematoma has a direct impact on prognosis. You're going to see that ipsilateral pupil dilated and fixed if you've got a really severe hematoma. Remember, ipsilateral is on the same side. Remember that if you've got a blunt force injury that's producing that acute subdural hematoma, a lot of times you've also got some underlying brain injury that's also, you've got working against you the development of cerebral edema. So you've kind of got two things going at you at the same time, both of which are going to impact the risk for increasing intracranial pressure. And if you've got the cerebral edema on top of the subdural hematoma, then that makes the prognosis worse. A subacute hematural is typically going to manifest within 2 to 14 days after the injury. And what will happen is after you have that initial bleed, then you're going to see this hematoma is going to appear to enlarge over time as the breakdown of the products of the blood draw blood fluid into the subdural space. So it's going to come in on here, like I found on the slide, between 2 to 14 days and enlarge over time. Then you can have a chronic subdural hematoma. This develops over weeks or even over months after it seems like there's been a minor head injury, and then weeks or months later you're going to start to see symptoms. This is more common in the elderly, and if you stop and think about that, that makes sense, because as we age, the brain shrinks. So you've got larger subdural spaces as a result of the brain atrophy. With the atrophy, the brain remains attached to the supportive structures, but the tensions increase and is more subject to tearing. The larger the size of the subdural space also accounts for, you might see the complaints be more focal symptoms rather than generalized. A precipitating factor is that chronic alcoholics are also very prone to cerebral atrophy and the development of subdural hematomas because they tend to fall more, and so they've got kind of two things going against them. A lot of times in the older individual, we won't pick up on a chronic subdural hematoma as quickly as maybe we should because they have symptoms that mimic other problems that are common in the elderly, such as increased sleep or somnolence, confusion, lethargy, memory loss. Sometimes we don't recognize that it's a chronic subdural hematoma. Instead, we think that it's a TIA, or sometimes even go down the path of dementia. This is just a slide showing you the visual of the different anatomical locations of an epidural, subdural, and subarachnoid hematoma. And that's, again, just for you if you're visual. An intracerebral hematoma occurs from bleeding within the brain tissue, and it accounts for about 16% of head injuries. It's usually going to be in the frontal and temporal lobes, possibly from the rupture of the intracerebral vessels at the time of the injury. And again, the same thing, the size and location of that hematoma is going to have a direct impact on the prognosis and the patient's outcome. When we look at diagnostic studies, the CT is the best diagnostic test that we can use for head trauma because it allows for a rapid diagnosis and intervention in the acute care setting. And we know, that this patient might need cranial surgery, so the quicker we can get a response, the better. We can use some other things such as the MRI, the PET scans, the evoked potentials. And this can help us to differentiate between the head injuries. Then MRI is more sensitive than a CT, so we can usually use that when we're looking for small lesions. We can use a cranial Doppler, and that measures the velocity of the cerebral blood flow. We might be looking at the cervical spine x-rays because a lot of times we'll have a cervical spine trauma at the same time that we have a head injury. In general, you want to use the same diagnostic studies that you would utilize for a patient with increased intracranial pressure. And one of the things we can do from a perspective without invasion is we can do the Glasgow-Coma scale. From a collaborative standpoint, when we look at emergency care, we want to do the things that are on this slide, and I have listed these out for you. I am not going to elaborate on them because it pretty much tells you what you need to do right there when we're talking about emergency care. We're going to talk a little bit about maintaining warmth. Ongoing monitoring of that patient with a head injury is very, very important. But we may need to use things like blankets or warm IV fluids. We also might use warm humidified oxygen. We could use overhead warming lights. We've talked about the importance of good assessment, that ongoing monitoring. We're watching level of consciousness, vital signs, O2 sats. We're going to do repetitive Glasgow-Coma scales. We're watching pupil size, their reactivity. We're watching cardiac rhythm, and we're looking for any type of rhinorrhea or otorrhea. Anticipate that we might need to go with intubation. Always assume there's a neck injury with head injury until that's ruled out. We want to be careful about administering fluids. Why do we want to do that? Because if we overload them with fluid, we are once again going to increase their intracranial pressure. Our principles are that we want to take measures that prevent secondary injury by treating the cerebral edema and managing increased intracranial pressure. We want to have a timely diagnosis. We want to get them into surgery quickly if we need to. For the patient with concussion and contusion, observation and management of increased intracranial pressure are the primary management strategies. So I'm not going to really beat those into this particular collaborate because you can go back to that longer collaborate on increased intracranial pressure and review those. Skull fractures, it's usually conservative. If we do have a depressed skull fracture or fractures that have loose fragments, we might be looking at a craniotomy to elevate the depressed bone and remove the free fragments. If there's a large amount of bone that's destroyed, the bone might have to be removed, i.e. a craniectomy, and a cranioplasty would be needed at a later time. In cases of large acute subdural and epidural hematomas, or those associated with a lot of neurological impairment, the blood has to be removed through surgical evacuation. We can do the craniotomy. It's generally performed to visualize and control the bleeding vessels. We can also do burr holes that can be used in an extreme emergency if we need a very rapid decompression, and then we would often follow that by a craniotomy. Sometimes they'll put a brain in. I'm sorry, I'm going to start laughing now. Sometimes they'll put a drain in post-operatively for several days to prevent the reaccumulation of blood. If we've got extreme swelling, they might do a craniotomy where they actually remove a piece of the skull to reduce pressure inside the cranial vault in order to cut down on the risk of herniation. From a nursing assessment standpoint, I've pretty much listed for you some things that you want to be watching for. Remember Cushing's triad. Again, if you don't remember Cushing's triad, you can go back to the collaborate on increased intracranial pressure where I talk about it quite a bit. We're just moving on. Some more data that you're looking for. When you're looking at musculoskeletal, I've got it listed up here for you. Some things to be watching for is the weakness, the palmar drift, paralysis. Remember spasticity versus flaccidity, and we talked about the different kinds of posturing. I've got for you, again, listed further things that we can do as far as gaining objective data, such as the CT, MRI. We're also would look for any abnormalities in the EEG. The location and type of the hematoma, edema, skull fracture, and or the foreign body on the CT scan. We're looking for positive toxicology screen or alcohol level. We might see either an increase or a decrease in the blood glucose level. We're watching for increases to the ICP. This list gives you the overall goals, and I've listed them for you, so I'm not going to talk more about them. This one here, let's see, this is acute intervention. Our general goal is to maintain cerebral oxygenation and perfusion, and we want to prevent secondary cerebral ischemia. So it's really super important that we pay close attention to monitoring them, and from a neurological status standpoint, because they can deteriorate very rapidly. This could mean that we need to get them in emergency surgery. We want to do the neurological assessments at intervals that are based on the patient's condition. We can continue to use the Glasgow-Coma scale. Indications of a deterioration in the neurological status, no matter how subtle, how little they are, and that could be something as simple as a decrease in the level of consciousness or a decrease in motor strength. We should always report those very promptly to the healthcare provider and continue to monitor. Our major focus, which I've underlined in here, is nursing care related to increased intracranial pressure. So we're continuing to watch for that and manage. Some of the eye problems that we talked about those also in the collaborate about increased intracranial pressure. Might be the loss of the corneal reflex, the periorbital ecchymosis, and edema. Might see diplopia. We could lose. We might need to consult an ophthalmologist. We can remember that if they've lost the corneal reflex, that we need to maybe be administering lubricating eye drops. We might need to take the eyes shut to prevent abrasion. That periorbital ecchymosis and edema typically is going to decrease with time, but we could use initially cold and then later warm compresses to give comfort and help to make that process move along. We can use an eye patch with diplopia. Elevations in body temperature, of course, can cause an increased CBF and therefore increase our cerebral blood volume, and then that leads directly into increased intracranial pressure. So sometimes we'll see that secondary to hyperthermia. We want to avoid hyperthermia. We want to keep that temperature in the same goal that I talked about back on that other collaborate between 96.8 and 98.6. Remember, you can just transpose the last two digits and you've got your range. We want to use interventions to reduce temperature in conjunction with sedation as necessary to prevent shivering. We can see some major behavioral manifestations, and you can end up with a patient who's very frightened, disoriented, and as a result, it can become very combative. We need to make sure that we're keeping the caregiver and family well informed of what's going on. Oh, goodness. From a nursing implementation period perspective, we're continuing to do the things that are on this slide. If we see that we have rhinorrhea or otorrhea, we want to inform the physician immediately. Remember that elevating that head of the bed can decrease the CFS pressure, so that and that will help the tear to seal. If they have otorrhea or rhinorrhea, we can put a loose collection pad under the nose or over the ear. Never, never, never place a dressing in the nasal or ear cavities. We want that patient to avoid sneezing or blowing the nose. We should not be using a nasogastric tube, and we should not be doing nasotracheal suctioning. and that's because either of these things can increase the likelihood of them developing meningitis, which they're already at high risk for. Remember, we need to address issues of the immobilized patient, and I know you guys know that, so I'm not going to run through all those things again. That if the patient's condition deteriorates, they may need intracranial surgery. The emergency nature of the surgery might kind of curtail or shortcut some of the preoperative measures. So sometimes we need to talk to the neurosurgeon to find out exactly what we need to get done and what we can go ahead and not get done so that we can get them into surgery very rapidly. A lot of times the patient's going to be unconscious before they go into surgery, which is going to push all decision-making over into the family, and this can be very frightening or scary for them. Let's see. Ambulatory and home care. After they've been in the hospital, the next place they're going to go is acute rehab. And this might be where chronic problems related to motor and sensory deficits, communication, memory, and intellectual functioning are going to be addressed. Some common conditions that continue to show up are poor nutritional status, problems with bowel bladder management. We could see spasticity, we can see dysphagia, we could see the development of DVT, or even the development of hydrocephalus. In about 5% of these patients, we're going to see seizures develop. With patients who've had non-penetrating head injury, they're most likely to develop in the first 7 days after the head injury. So again, we might use some prophylactic anti-seizure medications. Probably the toughest thing related to TBI is the mental and emotional impact of brain trauma, and that can be the most incapacitating. That patient who's had the TBI sometimes kind of loses a sense or grasp on what's realistic, and they also can undergo personality changes, particularly if they've ever comatose for a significant length of time. They can lose the ability to concentrate. They have memory problems. They have difficulty processing information. They can get very apathetic. They have mood swings. They seem to have a lack of awareness of how serious the injury is, and they just have kind of a whole total lack of some of the inhibitory functions that we have, just as in relationship to judgment and tact and emotional control. The rehab is going to go on, and sometimes it's going to take as much as 6 months before we hit a plateau, and only whenever that plateau is hit can there be any kind of a reasonable prognosis of what the recovery is going to be. Sometimes whenever we discharge that patient, we also may discharge them with what's called specific no's, and that's an NO, like the word no, like yes and no. So there are some things that sometimes we'll just say, absolutely, this person can't do. Like, for example, it might be no drinking of alcohol. It could be no driving, no use of firearms. They can't work in hazardous situations, no unsupervised smoking. So sometimes they're discharged with a list of what I call no's, okay? We're continuing on, still talking about acute rehab. Pretty much everything I want to tell you on here is primarily on here with one particular extra thing. Sometimes people can look like they're doing great. They're in rehab, they've got hydrated, the physical manifestations of their injury have healed, and they look like they're doing just really super great. However, a lot of times there's really not any idea what's really going on with them. And the outward appearance does not necessarily reflect what's happened in the brain, and it's not a good indicator of how they're ultimately going to be able to recover and function. But they may look great from a physical standpoint. Moving them on home into ambulatory and home care, we still might have some issues with seizure disorders. Although they do typically happen within the first week of injury, some patients might not develop a seizure disorder until years after that initial injury. They continue to have the same issues with the mental and emotional difficulties. If they did not stay in rehab until they hit a plateau, we're still talking about that progressive rehab. The family really needs to have good support. You might have to look at some broad referrals out there to help them get access to the different resources that they need. Sometimes we just really have to make sure that that patient and that family is kind of thinking down the long-term picture. This slide talks about brain tumors, and the brain tumor survivability rate for a primary site brain tumor is about 36%. We classify brain tumors by the type of tissue from which they arise. You can look at table 57-12 for the most common brain tumors. I give you some information on here that as far as primary tumors, 34% of those are meningiomas. Gliomas, if you've got a glioma, they're about 30% of all brain tumors, but they're 80% of all malignant tumors, and a glioblastoma multiforme is the most common glioma. The other way we develop brain tumors is a secondary result of metastasis, and actually a metastatic brain tumor is more common than a primary brain tumor. Some common sites where we're getting metastasis from are the lung and the breast. How the symptoms manifest really depends on where the tumor is at and how large it is. So you can have a wide range, and I've kind of listed those out there for you. I'm not going to read them to you, so I've listed them out there for you. So in doing diagnostics, again, you want to have a good history. If you've got an adult onset of either migraines or seizures, that's a really telling symptom for you to take note of. And then I've also just listed here for you on the slide different ways that we can further diagnose. The gold standard, of course, is that we want a tissue sample in order to identify the malignancy. Sometimes we get that tissue sample actually doing surgery, or we can do a stereotactic biopsy so that we can get it ahead of time. From a collaborative standpoint, we want to figure out what the tumor type is. We want to either remove or decrease the tumor, and then there's that good old intracranial pressure again. So we either want to prevent or manage increased intracranial pressure. And the reason I say you decrease tumor size, some of these tumors you can't get all of. So we're going to move on to surgery. Complete removal of a tumor is not always possible. Sometimes that tumor might not be accessible, or it might be wrapped around or involve vital parts of the brain. The outcome is based on the location and size. Particularly gliomas and medulloblastomas are very invasive, and often they are some of the tumors you really can't get all of them. We can use surgery to reduce symptoms and extend survival if we can't get all of the tumor. We have more and more technology out there, and so if you've got a small tumor now, sometimes we can do that surgery using stereotactic techniques and really cut down on the trauma that that patient goes through. We also can use radiation and chemotherapy. Some of the complications of radiation are cerebral edema and increased intracranial pressure, that good old increased intracranial pressure. And we'll often manage this with some high doses of corticosteroids. Chemotherapy, we have some complications when we think about chemotherapy. It's complicated by the blood-brain barrier, drug resistance, and also the fact that the tumor itself is very different. It has a high degree of what's called heterogeneity. That's very, very different. However, in most malignant brain tumors, that brain tumor, and we talked about this in oncology already, how aggressive malignant tumors are. So in most malignant tumors, that tumor is actually going to break down the blood-brain barrier, and so then chemo, we can get into the brain much easier. Guess that's a good thing, bad thing, I don't know. We typically are going to use nitrosteroids, and I've given you a couple of examples. Some other things we can do is we can actually implant chemo wafers. They can be implanted during surgery. They're biodegradable. They'll eventually disintegrate. A special type of thing that we can do is an Ommaya reservoir. Remember, I talked about this in oncology already, and that's for intrathecal administration. And like I think I talked about it quite a bit in oncology, so you can also go back and reference those notes as well. We do have an oral chemo that we can use. Temozolomide is the first one that really crosses that blood-brain barrier. We talked about bevacizumab in oncology, trade name of Avastin. We already talked about it and how it inhibits vascular growth. So those are a couple of other things. Then moving on to nursing assessment. I've listed for you data. I'm not going to talk more about it. You can read that. The next slide is the same. This is nursing intervention. Again, you can read that. I don't need to read it to you. We're going to move over to cranial surgery. There we are. Surgery can be related to a brain tumor, or if there's an abscess that we need to deal with. We can also do surgery for vascular abnormalities, sometimes from cranial trauma. We just talked about that. We can also do it for seizure disorders. We can do a craniotomy. And in a craniotomy, we just have a series of burr holes, and we connect the burr holes with a saw, and then we lift out the bone flap. After we're done what we're doing, we replace that bone flap after surgery. Or the stereotactic radiosurgery, we can start with either burr holes or a bone flap. And what this is precisely focused radiation. We can deliver that radiation in a single treatment over several hours, or we can have multiple sessions with the radiation. So the bottom line is you start with the burr holes, and sometimes you do the burr hole, sometimes you have to have a flap, you put the biopsy needle in, you do the radiation, you move on, okay? We also have more technology. We can use stereotactic lasers, and this is completed with the use of 3D computer images. We want to keep that patient very still, so they're in something called a stereotactic frame. There's 3 different kinds of lasers. All of them use thermal energy in order to destroy the targeted tissue. So even though there's different kinds, they work by the same principle. Post-surgical care, once again, we're talking about that increased intracranial pressure. We're going to pay very, very close assessment of neurological signs, particularly in that first 48 hours. We're watching for fluid electrolytes and serum osmolality. We're looking for changes in sodium regulation, the onset of diabetes insipidus, or severe hypovolemia. We can use antiemetics for nausea and vomiting. However, we want to avoid Phenergan, or the generic name is promethazine, because it can also cause somnolence, which we then can mistake. It's going to make us more sleepy. That's all I mean by that. And so it's going to alter the accuracy of our neuroassessment. So we want to try to stay away from that. We can use short-acting opioids for pain. We want short-acting for the same type of reason. Okay? Post-surgically. When we think about positioning is going to depend on the incision location. And I have put this on the slide because I want you to know this, and I don't want you to say, I didn't get it written down. So it depends on the incision location. So if you've got an anterior or middle fossa, you're going to elevate the bed 30 degrees. If you've got posterior fossa or a burr hole, you're going to have flat or slight elevation of the head of the bed, 10 to 15 degrees. If you've got a bone flap, do not position them on the same side as that bone flap, okay? And we're going to move on to the last slide. And again, the dressing usually stays in place for a few days. You want to be monitoring for color, odor, and amount of drainage. If you've got any excessive bleeding or an excessive amount of clear drainage, we want to notify that physician. They may have a drain in place. If so, you want to monitor that and monitor the output from that. You want to do everything you can in your scalp care to prevent infection. So when that dressing is removed, if you're going to do any washing of the scalp, you want to make sure that you're using an antiseptic type of soap. And that wraps this collaborate up.